Simone Gleeson, your RACGP staff host for tonight. You should be able to see our two presenters on your screen. However, you will only be able to hear my voice, not see me. Okay, so as many of you may not be familiar with the GoTo setup, we thought we'd just take a couple of minutes to help you feel comfortable and provide some options to you for communicating with us. First of all, though, I just want to point out, if you do experience any technical difficulties, there's a phone number at the bottom of your screen which you can phone. I'll just run through a couple of quick basic tips to help you. So throughout the webinar, we'll refer to your control panel, and that is what you can see on your screen at the moment. So if you're using a computer to participate, you should be able to see a box like that one on the picture on the PowerPoint slide. Look for the little red or orange arrow up there, and that is how you can open and close your control panel. So you're aware, although you can see our presenters, we can't see you, and so you don't need to worry about that. We've also set all of our participants on mute from this end, so that again means any noise that you make at your end won't be able to be heard by anyone else during the presentation. If you do, however, have a comment or a question, then you can send them to us via a type message in your question section of your control panel. And we will also type some notifications and replies to you throughout the presentation. So getting back to the questions, to do that, you'll see the area of your control panel entitled questions, and you can open, it can expand or collapse that box by clicking on the plus or minus sign. So obviously when it's open, that allows you to type the question. We're actually going to trial that feature now. So, so that you can practice using the question bar, I'll ask that everyone please type in to that little box the location, the suburb or town in which you're currently located. And then we can have a look and see where in Australia everyone is tuning in from today. So I can see people are doing that, which is fantastic. We've got quite a lot of people here tonight, so it's wonderful. We've got people from Warrnambool, Alice Springs, Perth, Bellevue Hill, Adelaide, Leongatha, Darwin, Bendigo. Fantastic. That's really great. So it looks like most people have got the hang of that. Please do use this feature as questions come to mind, and our team behind the scenes, Lynelle Kogan is with us behind the scenes, and she will be able to assist where you need or answer your questions. We will, however, also save many of your questions or address them during the Q&A session towards the end of the presentation. Okay, the last feature I want to show you very quickly is polling. Polling is a great way for you to feel like you're in the same room as us, and we're going to also practice this feature now. So Lynelle is going to launch a question, and you'll have that appear on your screen. What describes your current role? So if you could please select the answer there that's most appropriate, and those results coming in now, and then we will in a moment share those with you. So it looks like we mainly have, wow, we've got, wow, mostly GPs here, so not too many practice nurses at all, but that's great. Hopefully you'll be able to take back to your practices what you gleaned from tonight. All right, well now for the presentation. So I'm delighted to welcome Professor Mark Harris. Mark is a stalwart in the area of chronic illness prevention and management and a leader in primary healthcare research. Mark is Foundation Professor of General Practice as well as Executive Director of the Centre for Primary Healthcare and Equity at the University of New South Wales. Mark's worked on several editions of our guidelines in this space, including the SNAP guide, which he led. Mark's your host for this evening. Thank you, Mark.
Thanks very much, Simone. So if I could have the next slide, or the slide after that. So I'd like to introduce my co-host for this evening, who's Karen Booth. Karen's our respected and proactive primary healthcare nurse and practice manager, and she's president of the Australian Primary Healthcare Nurses Association, APNA, and a leader in creating an environment for preventive health, and one of the co-authors of the SNAP Guide. So if I could have the next slide. So we're talking, we're going to be presenting some material from the SNAP Guide. The SNAP Guide covers some information about why risk factors are important and why general practice has a key role. It also introduces a 5-step model of 5 A's, which is about ask, assess, advise, assist, and arrange for the detection, assessment, and management of the SNAP risk factors. So SNAP stands for smoking, nutrition, alcohol, and physical activity, and we've put weight in there as well. And the first half is about clinical management, and the second half is about practice strategies and practice organisation to apply the SNAP approach in general practice, including use of resources, tools, and referral services. So if I could have the next slide. So the SNAP Guide's built around the 5 A's, and the 5 A's stand for ask, assess, and we're assessing patients' level of risk, their motivation, and their health literacy in particular, and then providing brief advice, and that may be in written or verbal information, maybe including some motivational counselling, and then providing some goal setting, so negotiating some agreed goals and targets. The next A is assist, and that really involves developing a risk factor management plan, which may include lifestyle education tailored to the individual, and also some advice about self-monitoring and support. And the last A is about arrange, and that's arranging referral, because referrals often required, particularly for the risk factors that we'll be talking about tonight, which are diet, physical activity, and weight, and because it's often not enough to provide brief advice and assistance. The other part of arrange is follow-up, because these are long-term problems, and it's very important to follow people up to try and prevent relapse and to manage relapse when it occurs. There's evidence that each one of these steps, as you move from just assessing people's risk and providing some brief advice to goal setting and assisting and arranging, each one of those steps increase the likelihood that someone will be motivated to actually change their lifestyle by about 20 to 30%. It varies with the risk factors, but that's the sort of level of improvement that you might be expected to achieve by making sure that you go through all of the 5 A's and don't just stop at the first couple. So the next slide. So we'll start off with overweight and just work through some of the 5 A's principles for weight, diet, and physical activity. So with overweight, in addition to health literacy and people's motivation, it's important to assess their level of risk, and the key measures of risk that really tell you almost all that you need to know about someone's level of risk is body mass index, which of course is weight in kilos divided by height in meters squared, and waist circumference, and there's obviously different ranges for men and women. So, and waist circumference is an important predictor of risk, especially for diabetes and for metabolic syndrome. The next A is, and clearly part of the assessment includes looking at diet and physical activity, which we'll talk about in a moment. In terms of advise and agree, it's important to provide brief advice on diet, and really what we're aiming for, this is not what you say to patients of course, but what we're aiming for in terms of trying to help people lose weight is about that their energy intake would be about 2,500 kilojoules less than what they're usually taking in. and that's usually enough to achieve a modest weight reduction, together with physical activity. And again, we're wanting to have physical activity on most days of the week, and that's about 300 minutes in a week at least of moderate activity, or 150 minutes of vigorous physical activity, or a combination of the two. And agreeing on targets, of course, the most important targets are about diet, which we'll talk, and physical activity, which we'll talk about. But in terms of weight, what we're interested in is a target, something that's going to achieve a weight loss of about 5 to 10%. That's might not achieve people's ideal body weight. They might be still well short of that, but it's enough to bring about some real physiological improvements in things like lipids and blood pressure and risk of diabetes. And then the next A is developing a weight plan. And here it's obviously about not just self-monitoring of weight, but making changes to diet and physical activity. And this often depends on what we've found out previously about the patient's diet. The next A is arrange, and again here usually this will involve referral. It's very difficult in standard consultations to really provide enough support and advice and education, really. And so referring patients to a diet and physical activity program, particularly if it involves some behavioural modification as part of that program, or that service, or that provider. So it may be a dietitian, or a group program, for example, or it may be even telephone coaching. In New South Wales and South Australia and Tasmania, there's a telephone coaching program that's available from the state government. There's also, I think, a coaching program, a different one in Victoria. And so telephone coaching has been shown to be quite useful, particularly in supporting people not just to make changes but to maintain them. The next thing we want to look at is nutrition, and assessing here. Assessing diet's very complex, and there's some key things we want to look at. Fruit and vegetable portions, portion size, so the amount people are eating, and meal size that they're having. So a portion is fruit and vegetables, for example, is about ½ a cup, and the target is 5 to 7 portions of fruit and vegetables per day. But looking at people's portions of other foods is important in estimating their total kilojoule intake. Also asking about diet behaviours like binge eating or snacking between meals, etc. They're really trying to identify where the problem is. And then providing brief advice, and this should be really structured around the dietary guidelines, which include, as I've mentioned, 5 to 7 portions of fruit and vegetables a day, and agreeing on what changes to the diet will be made. So some very practical, specific goals there. For example, not drinking sugary soft drinks might be a change that someone agrees to make. And then developing a plan and providing some self-help materials. This may include a chronic disease plan for patients who've got chronic disease, and so it may be part of a chronic disease plan. But really a diet which is usually structured around a healthy diet, healthful diet, for example, a Mediterranean diet, to try and improve the composition of what people are eating. And the next day is arrange, and here, if appropriate, consider referral to a dietitian or some other diet program or education program, and arrange for someone who's at risk for their nutrition to be followed up in 2 to 3 months to review what's happening with their diet. So the next risk factor we're going to look at tonight, and the last one, is physical activity. And again, as well as health literacy and motivation, we're assessing, we want to assess the level of physical activity. What we're interested in is the type, intensity, frequency and duration of that physical activity that's going on. And there's some questions that you can ask. So there's a number of screening questions that can be used, but that's really what we're after. And we're also after sedentary behaviour because that's clear, that's increasingly important. We know that that's a very significant risk factor for cardiovascular disease and diabetes. So the number of hours that people are spending sitting. And then, again, tailoring advice to patients' level of risk. In other words, how little physical activity they're doing now. You want to build that up. It may not, you don't want to suddenly come sort of double or triple the amount of physical activity. You want to build it up over a period of weeks. But it also needs to be tailored to patient's age. So here we've got on the screen the recommendations for patients 18 to 64, which is 150 to 300 minutes of moderate activity, but 75 to 150 minutes of vigorous activity per week. Also some muscle strengthening and reducing sedentary time. So trying not to be sitting for more than an hour at a time, having a break, trying to not have prolonged periods of sitting is very important. Now there's different recommendations for children and for older people, so you really need to look at the SNAP guide and look at what those are. So you can tailor the advice to the patient and agree on what's a reasonable specific goal. Now specific activity might be, I'll agree to, you know, walk the dogs at a brisk pace for 30 minutes 6 days a week or something. That's a very specific goal, and that's the sort of thing that is important to come eventually to with the patient, agreeing with the patient. And then assisting with written information, possibly with some physical activity counselling, which might be face-to-face or, as I mentioned, on the phone. It might involve an exercise prescription, and you can use, you don't have to use the fancy Fitbits and so on. You can use the cheaper and older pedometers to count the number of steps that people are making, particularly if their physical activity is mainly in the form of walking or ambulating. Then the pedometers can be quite useful, particularly in getting an idea of how much, both for you and the patient, how many steps they're taking in a day. And they don't necessarily have to be meeting the target of 10,000 steps in a day, but you want to increase their number of steps per day. Well, something happened to the screen. Yep, we're back again. And the next slide is a range. The next thing is a range, considering referral, for example, to local community programs, walking groups, health programs, heart moves programs, depending on, again, the patient's needs and what you're trying to achieve, and following them up for their physical activity over 3 to 6 months. So there are just 3 of the SNAP risk factors. We haven't talked about smoking or alcohol, but what we're going to do now is to look at a case study, and I'll just read through some of the information which you can see on your screen. Patrick's 49-year-old accountant, recently diagnosed with hyperlipidemia, and he's got normal fasting glucose, and his hyperlipidemia is largely controlled through diet. He's not on medications. His blood pressure is 130/85. We calculate his cardiovascular absolute risk, and it's about 6%. So that puts him in the low risk for in terms of having a cardiac event in the next 5 years or a stroke. His weight's 107 kilos, and his body mass index is 31 kilos. His waist circumference is 103 centimetres. You just need to remember that. So it's 103 centimetres. And he doesn't smoke, and he drinks 0 to 1 standard drinks per day. So we've got our polling question next. So how would you rate Patrick's level of risk based on his waist circumference of 103 centimetres? High, increased, or low? Okay. So yeah, so it's actually 103 centimetres as is considered high. Above 102 centimetres in men is considered at high risk. So it's just in the high risk category. And I think it's above 94 centimetres is in the increased risk category. So we measure waist circumference around in between the if you put the tape measure between the lower ribs and the iliac crest, halfway between, which is roughly around the navel. Obviously it depends on how overweight someone is. That'll give you the waist circumference. Okay, so what are appropriate actions to take in this patient across each of the 5 A's? Well, we'd like to, as in addition to the information we've already got, and some information about his health literacy and motivation, we'd like to assess his diet. For example, we'd like to ask how many portions of fruit and vegetables he eats and his eating pattern. We might give him some advice, and the first thing we might really talk with him is the importance of reducing his weight, and that this is a risk factor, particularly in terms of his blood pressure, which is in the high normal range, and his lipids, and of course ultimately for heart disease and diabetes. We might advise him to make some changes to his diet, such as, depending on what we find out about his diet, reducing fat or cutting out soft drinks or reducing portion size. Some fairly simple advice we could start with at least. And we might agree that what we're aiming for is a target of 5 to 10%, or around, in his case, around 5 or 6 to 10 to 12 kilos. And we might be aiming for that. Again, that's what we would have to agree with him about. That might be, he might want to lose that very quickly or a little bit more slowly. Doesn't really matter. The evidence is, you can. The important thing is to lose the weight, and then the really difficult thing is to keep the weight off when you've lost it. We could assist him by offering referral to a phone coaching program, because it's unlikely that the sort of advice and information that we give him is going to be enough. He probably needs some more detailed discussion of his diet particularly, and we haven't talked to him about his physical activity, so he needs some advice about that, and we want to follow him up certainly within the next 2 months. Okay, so that'd be appropriate actions for Patrick. So this is all very well, but in theory, but how do we actually put it into practice? Well, this is difficult. If I could just have the next slide. This is some data from a study we did in 4 states in general practice, auditing general practice records. We've done it. They're actually a couple of studies, almost identical results. And this is the proportion of patients where blood pressure, smoking, alcohol, body mass index, or waist circumference was recorded. And as you can see, the recording of blood pressure and smoking is pretty good, and is up above 65%. And but the recording of alcohol, body mass index, and especially waist circumference is not so good. There's lots of room for improvement there. So this is an area where we need to be doing better. The BMI figure really relates to whether weight and height was recorded in the medical records, and whether weight had been recorded in the past 2 years and height ever recorded. Okay, so if I could have the next slide. So the other side of this is, that's really just about assessment. So there's some gaps in our assessment, especially of body mass index and waist circumference. This is another study from a big cohort study in New South Wales called the 45 and Up study. And patients were asked, have you had your blood pressure, blood cholesterol, or blood glucose checked by your GP in the past year? And has your GP offered you advice on your dietary fat or fruit and vegetables or physical activity. And as you can see, most patients said that in the past year they'd actually been offered to have their blood pressure, cholesterol and blood glucose checked. And this is actually more frequently than you might expect because, for example, in patients who don't have hyperlipidemia, we'd be recommending cholesterol testing only every 5 years. However, the proportion getting dietary advice is much lower. So again, there's a barrier there that we need to address. And I'm going to hand over now to Karen to talk about some of the issues.
Hello everyone. Some of the challenges to advice are around time. So time for GPs and for practice nurses can be in short supply. So you need to think about how can this be provided most efficiently. And it might be the first appointment with the patient's opportunistic, where you raise the issue for lifestyle change, but getting them to come back for planned visits where perhaps you tag team with the practice nurse doing some prep work and then handing over to the GP. The other issue is tailoring to the patient's needs, family and the social situation. Advice on diet and physical activity needs to be tailored to the patient's own situation. And for example, you need to think about the patient's readiness to change, what they understand about food labelling, culture, dietary problems, and portion size, things like binge eating or large portions, the like. And dieting is often a whole of family activity, and a younger person, single person, might be different. They're managing their own dietary needs. But one of the things I often hear from older adults is that, oh, I need to cook for the whole family, I can't cook something special for me. Or for a lot of men who just say, I eat what the wife gives me. So really you're not just targeting the person that needs the lifestyle change alone. You actually need to bring in their family and make it a whole activity. Follow-up visits, it might be worthwhile considering follow-up visits with practice nurse for support as well as coming back to the GP. Patient's understanding and recall. Does the patient actually understand what you're saying to them? Getting them to talk back techniques, including simple, clear communication, getting them to explain or repeat back to you what you've said. Have they understood? Maybe using diagrams and images, and encouraging questions like, what questions do you have, as opposed to, do you have any questions? So open-ended, asking them what else they need to know. And sometimes you may need to write that information down for them or have your resources ready to give them. And of course involving others, and they may be other providers, they may be other staff members within your practice, but also all of those resources that Mark talked about before, including web resources to help provide that consistent advice.
So thanks, Karen. So this is another graph. Sorry about these, but this is the last one you'll have to put up with. It's from another study that we did in general practice, and there's the 4 SNAP risk factors: nutrition, physical activity, alcohol and smoking. And the first set of bars, the yellow bars, are the proportion of patients who are at risk. So about 3/4 of patients were at risk for nutrition. They were either overweight or had poor nutrition. About a little over half were at risk in terms of their physical activity, about 1/3 in terms of their alcohol intake, and about 14% smoked. And the next bar, the light blue bar, is the proportion that got advice. So that's similar to what we've just been talking about a significant number of those patients who were at risk didn't get advice. But the next couple of bars are what I want to focus on, and that's the slightly darker blue and purple bar, and they relate to the proportion of patients who were referred for that risk factor, so referred to a nutrition program or something similar, and the proportion that attended. And as you can see, there's a gap between the proportion that were at risk and the portion that got, even those that got advice, and the proportion that got referred. There's a lot of scope for improvement, particularly for those patients where they're unlikely just to respond to simple advice and where they need some more intense education. So Karen's just going to look at some of the challenges that are involved in referral.
So some of those referral challenges are availability, what type of activity, where that activity might be, and affordability is also a very important issue for many patients. How much is it going to cost me? Is there a free program locally that you might be able to get your patient into, or do they have the ability to pay? What other referral pathways do you have for them where they might get some form of rebate for attending and paying for activities? Appropriateness is what will my experience be? Who else is going to be there, particularly for group activities? Is it a culturally appropriate group activity? Is it, patients are often a bit nervous attending particular group activities for the first time. And patient adherence can also be an issue. No-shows, dropouts, and particularly when these people may need a bit of extra monitoring and support. And I'd be thinking when you're reviewing those patients, getting them back to look at them and ask them what went wrong and maybe what were the blockers for that patient. And as Mark had mentioned earlier, for some people with chronic disease, it may be that one of the stumbling blocks for them is their mood, and that's worth assessing as well. Next slide. So implementation of the 5 A's. Ooh. I think we need to.
Oh, back.
No, I think we need to go back one. That's right. So assess risk, motivation and health literacy. So assessment can be improved by involving patients prior to the consultation. That might be engaging them in the waiting room newsletters. Maybe you have a practice newsletter or an app that they could pick up advice on. Advice and agree advice goals and goal setting. It can be made more effective by the use of things like tailored educational resources, motivational counselling. A lot of GPs and in fact a lot of practice nurses have actually experienced in motivational counselling, and help them with the pros and cons, those decision balance tools where you're looking at readiness to change. What are the good things about change? What don't I want to change? And you know that when they're looking at moving more towards the good things about change, that they're ready to move. And of course nurses are well placed here to help patients with that type of activity. Patients can be assisted through the development of an agreed plan and support to ensure there's sufficient time for appointments, for group sessions, and again bringing in the practice nurse for those a role in support. For those patients you have on chronic disease plan, they will get 5 visits from the nurse. But for Aboriginal and Torres Strait Islander patients that have had health assessments, they are entitled to 10 support visits for the nurse for lifestyle and monitoring. And referral can be enhanced by referral navigation, providing information about what's involved, where to go, transport costs, or cost to the patient, and early review of how successful that referral is. So back to follow-up, seeing how they're going, and having that suite of resources that Mark talked about ready at hand. So implementation strategies. I think getting your practice, setting priorities and a practice plan informed by a practice audit. So know where you are now and know where you want to go. Set your priorities and develop a plan for improving preventative care informed by the clinical audit and that whole of team approach. Definition of roles and responsibilities. Often this will involve clarifying roles, responsibility of the staff, what part the GP will do, what part the nurse will do, what part the practice admin will do. And it also helps to give those team members some ownership and hopefully some buy-in to your SNAP activity that you have planned. Records and register systems, so improved record, practice record and registering obese patients for follow-up, so whether how you code them, how you find them in your system, how you flag them, and patient education, so having patient education materials in the waiting room ready for the GP or the practice nurse to give to the patient as an addition to education. Good up-to-date referral information, and this will help in giving sufficient information to support patients, especially those with low health literacy, to navigate those referral services. And it may be that you need to explain that in a number of ways. And to make this a quality improvement approach, drawing on information from your audits and from patient feedback, and before and after measures of how your project's grown and improved, and make sure that when you do your measures that you celebrate your wins. And of course you can always keep those activities as part of your quality improvement activities to contribute to your accreditation when it comes around.
Okay, so thanks Karen. We're going to look now at a case study of a practice. This is staff of Greenvale General Practice, which includes 3 GPs, a practice manager, a practice nurse, and 2 part-time receptionists. And they conduct a clinical audit, and you've got some of the results from the audit there. The first column is just the risk factors, so smoking, recording of smoking, body mass index, waist circumference, blood pressure, and lipids. And then we've got the next column is the percentage of patients where those risk factors are recorded. So for smoking it was 62%, body mass index 34%, waist circumference 12%, blood pressure 72%, and lipids 75%. And then the last column is the percentage of patients where there was the risk factor recorded, because that's all we know, that were at risk. So in the 62% where it was recorded, 16% of the patients were recorded as smoking. In the 34% where the BMI was recorded, there were 61% who were overweight or obese. And in the 12% where waist circumference was recorded, 29% were at risk and 35% were at high risk. So there's different levels for males and females. And blood pressure, in the 72% of patients that had recorded blood pressure, 40% were either antihypertensive or had recorded elevated blood pressure. And lipids, in the 75% of patients that had lipids recorded, in those 75%, 70% of them were abnormal, had some abnormality in their total cholesterol, their LDL, HDL, or their triglycerides. So we're going to launch another polling question. Look at the first column. Remember we talked about the percentage that were recorded. Smoking was 62%, body mass index 34%, waist circumference 12%, blood pressure 72%, and lipids 75%. So which area do you think it's most important for this practice to improve their recording of risk factors? Okay, so clearly the lowest So 69% waist circumference, and that was clearly the lowest percentage, was 12%. And it's fairly simple to improve, to measure, but obviously takes a little bit of extra time. So that's sensible, I think. The smoking is important because, of course, smoking's a really strong cardiovascular risk factor, as well as being a risk factor for cancer and so on. So getting that up would be important. And similarly, the body mass index was only in a third of patients. But it certainly makes sense to try and make some difference with the waist circumference. Okay, so coming back to our case study, what are some appropriate priorities we might consider? So yes, we might try and improve recording, especially body mass index and waist circumference. And this is a role that can particularly be useful to try and do with patients as they present, particularly those who are newly enrolling in the practice or coming periodically to try and assess their, check that their weight and height and waist circumference is recorded, and having a kind of system for doing that. Some practices have got reward systems for trying to improve the recording of things like smoking is obviously important for things like for accreditation, but so are these other risk factors. Developing some patient resources, particularly that target diet. So we can't really tell much about waist circumference in the practice because it's only 12% recorded, but clearly amongst the third of patients that have had their BMI recorded, there's 61% of them who are overweight or obese. But also you notice that a really high percentage of the patients who've had lipids recorded are at risk. So, you know, more than half the patients have got abnormal lipids, which suggests that maybe they need to do something about, particularly their diet. And we might want to think about what are the referral options for diet and physical activity and weight reduction that this practice has got available. And for weight in particular, but really all the risk factors, it's important to have, as Karen was saying, really good information about the referral services. So it's better to have a smaller number. So, you know, one or two, you know, a few allied health providers, a really good local group program, and maybe a telephone coaching program, and really knowing a fair bit of information about that you can tell the patients, and so they can make a joint decision about going. And if they agree, they're much more likely to attend. So the next slide. So now I think we're over to you for some questions, and then we'll talk, after the questions, we'll talk briefly about some of the resources that are available.
Okay, we've got some questions coming in, Mark. So the first one I'd like to raise is we've got quite a few coming in. Yeah, can you please suggest appropriate ways to ask a patient permission to measure waist circumference? A number of patients are not keen on having their waist measured.
Mm-hmm. Yeah, well, I think the first thing is, I think it's important to explain to patients why you're doing it. You're not doing it to make them feel bad, and stigma associated with obesity in particular is really high in our society, so we need to take that into consideration. But I think it's about saying, you know, look, there seems to be a problem with your weight. What I'd like to do is to measure your waist circumference, because what that will tell me is about the fat that's inside your stomach, that's around your stomach and intestines. It's called omental fat, and that's really important because that tells us about your risk of diabetes and heart disease in particular. It's a dangerous sort of fat, and we want to keep an eye on that in addition to your overall weight. And it's particularly important in men because often men may not look that overweight, but when you actually measure their waist circumference, it's in the at-risk or high-risk category. So I think it's about explaining the purpose and then saying, so in addition to measuring your weight, I'd just like to check your waist circumference and see whether we can reduce some of that fat that's around your stomach inside you, not just under your skin, but inside you, and that's important because of that puts you at risk of things like diabetes and heart disease in particular.
Mark, I might also add that for patients sort of 35 on, it's worth doing a practice activity for the AusRisk tool, and the patients then actually tick those boxes and do their own waist measurements, if they can do it, and then just quietly write it down and then hand that to the doctor. And the practice that I've most recently been working at, it was a whole practice activity, and they marked that patient in a recall as to when it was due to ask them whether it was the next 2 year or if it was a 12-month review. But the patient then took that into the GP or into the nurse, and they were able to record it into the system. The patient realised, I think, by looking at their scores, scoring themselves, that maybe they did have a problem, and it was a bit easier then to actually initiate that conversation.
Yeah. And it's in New Zealand they've managed to, in general practices in New Zealand in particular, they've managed to get their a very high proportion of the patients risk assessed. So, but you've got to be sensitive in the way you do it.
Mm.
Another question, there's a large swing, at least in the community, towards low carb, high-fat diets for weight loss and sugar control, and people appear to be achieving great success. What are the thoughts on this, particularly given that it's direct contrast to much of the conventional diet advice given? That's one question, Mark. Thought I might throw in there just another question that's semi-related, whether you have any thoughts on the 5-2 diet. So just a couple of diet questions there.
Okay. Well, they're both complicated questions, but essentially, in terms of losing weight in the short term, there isn't really good evidence about what's the best way to do that, what's the diet that's going to be the magical thing that's going to help everyone. So having some flexibility, particularly about how people lose weight, so that 3 to 6 month period when they're trying to lose weight. And there is, for some people in particular, a high protein diet, a diet that's relatively high in protein and fruit and vegetables, so not just, but relatively low in carbohydrates, can help reduce some of their hunger and be useful. And some of the very low energy diets, the meal replacement diets, like I shouldn't use a proprietary one, but there's really only one that I'm aware of being really rigorously evaluated. I think there might be two actually, there's another one, but Optifast, for example. Relatively high protein, relatively low carbohydrate. And I say relatively, it's important not to go overboard. The high fat part of it is unhelpful, I think, and there's pretty good evidence that high fat, even short term, is not a good idea because of its risk. It really does increase your risk of cardiovascular disease. Again, it depends a bit on what the fat is. If you're talking about polyunsaturated fats, vegetable oils, particularly things like olive oil and so on, a modest amount of that in the diet's useful. So I think that that's a fairly long-winded answer to the question about those diets. So not high fat, but a high protein does suit some people, but other people really, it's a question of just having a low kilojoule diet. What ultimately it comes down to is you've got to get the kilojoules down in the diet. If you can't do that, then you're probably not going to lose weight, no matter what kind of configuration that is. So high protein, low carbohydrate can be useful, but doesn't suit everyone. And it's not the only way to lose weight, and ultimately you want to make sure that people are eating less kilojoules. Longer term also, the best evidence for a healthful diet long term is the Mediterranean diet, which does tend to be a bit higher in carbohydrates and some of those polyunsaturated vegetable oils than traditional Australian diet, but is relatively low, a little bit low in carbohydrates and high in fruit and vegetables. So, the very high protein diets, there is some evidence that longer term they may be a risk in terms of heart disease. So I think you need to think about it in two ways. What's going to help this person lose weight in the relatively short term, so 3 to 6 month period, and then how are they going to keep that weight off in a diet that's going to be safe for them and going to not just help them to maintain their weight, but also to be healthful and at low heart disease risk and low diabetes risk, etc. So that's about the state of knowledge at the moment. There's all sorts of complexities you can throw in there, the biome and so on, but essentially you're trying in the short term to really cut out about a quarter to or a fifth of the kilojoules that people are eating and get some weight loss and then maintain that with a healthful diet, something like the Mediterranean diet, which you can find, by the way, on the RACGP. There's a good description of it on the RACGP website, which is called, it's just gone out of my head, the one that Paul Glasio has developed.
Handy.
Sorry? Handy, yeah, H-A-N-D-I. If you Google that, RACGP Handy, and it'll come up, and you can find the Mediterranean diet well described there. That's good for sort of maintenance along with physical activity. Yeah, physical activity is important. It's really critical for weight maintenance and trying to prevent a lot of weight gain. Even if people gain a bit of weight, that's still useful. The other question, sorry I'm taking so long to answer this, but they're really complicated questions. 5-2 diet, again, it suits some people, and again, as long as you're careful about how you do it and you don't go overboard, it can be a useful tool for some people. Some people find it's an easier way to diet. The evaluations of it, though, haven't really been, rigorous evaluations haven't been done, so it's still a bit of an open question, but again, I think for a short period of time, if it helps people to lose weight, then it's fine, but it's not something that's sustainable long term.
Okay.
My addition there to the low carb would be to say that, tell your patients that low carb beer doesn't mean low calorie.
Yeah, that's right.
So I'd just like to point out any questions that we don't get to this evening. We will be, the presenters will have an opportunity to review those and provide answers to you, and we will be sending a copy of those out via email, any that we don't get to tonight. So there's another question, how would you approach the GP management plan development for patients who are smokers or obese, but who do not necessarily have chronic disease?
Well, Karen might like to comment on this, but it's a problem because currently there's a sort of a push to try and get obesity recognised as a chronic disease and therefore enabled to have a care plan for someone who's just obese. At the moment, though, that probably, and there is some debate about it, but probably that's not sufficient grounds to say someone's got a chronic complex condition. But many people who are obese also have another condition, and so if they've got other problems, for example, they might have hyperlipidemia and obesity, or hypertension, or clearly diabetes. So any of those things might be enough to tip them into the complex category, which would justify that. But there is a lot of debate about that and representation about it. There's parliamentary committees going on at the moment. So hopefully it will be recognised for the purposes of the care plans as a chronic illness, but it's not. I don't think at the moment you can be confident that it fits that criteria that they currently have. Karen, have you got any thoughts on that?
I think the Medicare descriptor changed a little while ago where it described hyperlipidemia and hypertension as a symptom, so that's gone now, so that they're no longer just described as symptoms. And there was a move to where people, as Mark said, had a complex set of conditions and would be better managed under some sort of care, as long as you were judged by your peers that that was a reasonable way to manage that person and their risk, then you might be able to justify it. But I think probably what you need to do is to maybe look again at the Medicare descriptor before you actually move on to a GP management plan, even though for us it makes sense to actually manage the person better that way. It's just the referrals that will come after that. You can still make those referrals, it just means the patient might not get a rebate for them.
And the other thing, of course, is that there are free programs like some of the Medicare locals and now Primary Health Networks are running some programs, and we'll talk about some of those. And there are telephone coaching programs. And I want to really emphasise that because it's one of the things that's available in many locations because it's available on the phone. If you refer them to the coaching program, the one in New South Wales called Get Healthy, then they will ring the patient back on their phone or their mobile, so they won't have to pay the cost of the call. And they'll ring them back a couple of times a week and give them some practical advice and support. So it's a really good alternative for those patients who don't qualify for a care plan and referral to an individual dietitian or exercise physiologist or psychologist for that matter. And that's another thing, is that where there's a psychological problem as well, then you might be able to justify a mental health care, plan. And not all psychologists are good at giving interventions for people who've got eating problems or obese and have got need psychological support for their diet behaviours. But it's important to think about that as an option, particularly for patients who might be depressed and binge eating, for example, and they might benefit from some cognitive behavioural interventions that a psychologist might deliver. So you have to be creative, unfortunately. The system's not really geared to manage it perfectly at the moment by any means.
Thank you. We'll have to conclude the Q&A session. Karen, if you could give a wrap of some of the resources we've talked about tonight.
Yes, certainly. There's the Eat for Health website, which is the NHMRC initiative, and you can get your healthy eating guidelines, the Eat for Health calculator, and there's quite a lot of printable resources on that website. The 8700 website or app, and it has fast facts and kilojoules explained. the Healthy Kids website, the phone coaching that Mark just talked about, and the HEAL program from ESSA, which is the Exercise and Sports Science Association. And of course, there are many more resources listed in the SNAP guidelines that are hosted on the College of GP website. Thank you.
Thank you very much to Mark and Karen, and for everyone for joining us this evening. Please feel free to provide feedback to us. We will be also sending you an evaluation form as part of your QI and CPD requirements. But look, thanks again for joining us. We really appreciate the attention, and the webinar has now concluded.
Good night. See you.
Good night, everyone.